Hello, everyone. As you start to come in to the webinar, please open the chat box and tell us where you're from and what your role is in nursing. And we're glad to have you with us. Let's see who puts it in the chat first. All right, Rochester, way to go. Oh, welcome, Maureen. Becky from UCLA. Hi, Pat from Michigan. As Tracy's cracking up. And Heather. Oh, from Iraq. Thank you for joining. Awesome. All around the world. Yay. For those who are joining us, feel free to tell us where you're from in the chat box and the type of nursing you do. I suspect it's critical care, but I don't want to assume. And we'll wait one more minute and then we're going to go ahead and get started. I want to let everybody know, and you can tell your friends, that this will be recorded and posted. We're updating our website, so we'll have an education online learning section on the website where you'll be able to access the webinar. And I'm going to hand it over to Isabel and Joseph to introduce our speakers.
Thank you very much, Kathleen, and welcome to all our colleagues across the globe. We are privileged today to have two esteemed speakers, and they will take us through protecting kidney functioning in the septic adult patient. So I'm Isabel Kutsi. I'm from the University of Pretoria in South Africa. I'm also on the board of directors for the World Federation, and my portfolio is one of the directors of the Education Committee. So before I introduce Dr. Heather, I'm just going to hand over to my colleague Joseph, also from the Education Committee, just to introduce himself. Thank you, Joseph. You're on mute,
Thank you very much, Isabel. Thank you very much, here, Tracy. Welcome, everyone. My name is Joseph Tulenin Dimas Carrera, actually president of Association Mexican Nurse in Critical Care. It's an honor for me present excellent professor today in webinar, the organized World Federation of Critical Care Nurse.
Thank you very much, Joseph. So it's my pleasure now to introduce Dr. Heather Prebble. I'm just going to open her introduction here. So Dr. Heather has been a critical care setting for almost 30 years, so we are definitely amongst excellence here. Originally, she's from Chicago, and Heather's worked at Loyola University Medical Center for 12 years in the trauma surgical ICU before moving to Arizona. And after moving to Arizona, Heather started working at Banner University Medical Center, Phoenix, again in the TSICU. And during a tenure there at BAMP, her role included bedside nursing. She's a clinical education specialist, quality improvement specialist, and she's currently registered nurse certified specialist for critical care units. Heather's got a passion in education, and she has numerous posters and podium presentations. So we are really privileged to have her here tonight, and she will take us through the presentation with her colleagues. So Dr. Heather, you are welcome, and we are looking forward to your presentation. Thank you very much.
Thank you.
I'm going to hand over to Joseph now to introduce Tracy to us. Thank you so much.
Thank you, Isabel. Mr. Tracy is critical care clinical nurses specialized based in Phoenix, Arizona, working in the Mike Clinic. Tracy holds a Bachelor of Sciences of Nursing from Arizona State University, a Master of Sciences in Nursing from Grand Canyon University, and board certificate in adult health clinical nurses specialist. Certificate trauma registered to nurse and fellow of the Clinical Nurse Specialists Institute. She is currently pursuing her Doctor of Nursing Practice at Arizona State University and is passionate about advising patient care and nursing practice and improving healthcare outcomes for nurses, patients, and communities. Tracy has served in leadership roles with the American Association of Critical Care Nurses and Sigmated too. She serves of a scope of practical practice advisory committee for the Arizona State Board of Nursing and it is covering government affairs. Officer for the Arizona Nurses Association. She has spoken locally, nationally, and internationally, uh, and has published topics in critical care. Tracy is recognized for and committed to excellence, innovation, and advocacy in nursing. Welcome, Tracy, in the World Federation webinar of the World Federation of Critical Care Nurses.
Thank you very much, Joseph. So we are really privileged to have these two esteemed speakers tonight, and we invite you to sit back and relax. They're going to take us through the journey. You're welcome to write your comments in the chat box, and we will at the end have some time for some questions and comments. So please feel free during the presentation to add your comments in the chat box. And then also just to notify all of you that you will receive an email in the next 2 days with a QR code where we then kindly ask you to review the presentation, and then at the end of the review, you'll also be able to download your certificate of attendance. So without further ado, I'm going to hand over to our colleagues, Heather and Tracy, and thank you once again for the time and for sharing your knowledge with us. Thank you so much.
Thank you so much. We really appreciate the opportunity to speak with you all. And it's a passion of ours to talk about not only sepsis, but also acute kidney injury. So again, we cannot thank you enough for joining us. But we're going to talk today about under pressure, protecting the kidney function in the septic adult. So these are our disclosure statements for both Tracy and myself. And in looking at our objectives today, we're going to define sepsis and evidence-based management of sepsis. We're going to describe the pathophysiology and diagnostic criteria of acute kidney injury. And then we're also going to discuss some treatment options for sepsis-associated AKI. So let's start talking about sepsis-associated AKI, or SAAKI, and why it's important for us to understand. So we want to think about how sepsis contributes to high mortality and morbidity. And one thing is to understand the importance of distinguishing between sepsis versus sepsis-associated AKI. So in 2023, a group of individuals got together and really put forth a definition. It was the Acute Disease Quality Initiative Work Group, or ADAQI. They really set out to make sure that we understood that there was a difference between sepsis, AKI, and SAAKI. And it's really looking at the definition of the sepsis criteria using the sepsis 3 definition, and also the AKI criteria as set forth by the KDIGO definition. And the first thing we're going to talk about is our sepsis or SEP3 criteria. And those are used by a lot of entities such as like Society of Critical Care Medicine and CMS. Oh, wrong way. Hold on. Oh, sorry. Okay. So why is sepsis so important? Why is there such a focus on it? And the reason is that sepsis is common with almost 2.5 million hospitalizations. It actually has more hospitalizations than if we looked at patients with heart attack or with stroke combined. It's deadly. It has almost a third to a half of all hospital deaths are related to patients with sepsis. And then it's also costly. It can cost almost $50 billion to treat in the United States. So we really need to focus our attention on making this less of both the commonality, deadly, and the costly. It's also a major driver of our morbidity. So there's a threefold increase in moderate to severe cognitive impairment with these patients. There's disruptions in their activities of daily living. There's an increased risk of rehospitalization. About half of the patients will develop some type of psychological symptom. And then there's also an increase in the post-acute mortality. About half of the late deaths that cannot be explained by pre-sepsis health status. And then the staggering statistic that really stands out for me is that only a little bit over half of the patients that have developed sepsis can return back to work within 6 months. So it's really not only damaging to the patient, but also to their entire family. So let's start at the beginning. So when we're thinking about sepsis, we really need to clearly understand that it is a shock state and that is really kind of impacting everything. So simply put, that the patients will develop a shock state, which is an imbalance of the delivery and an imbalance of the demand of the oxygen. And there are 4 types of shock. There's hypovolemic shock, where there's a profound loss of volume. There's distributive shock, where there's an issue with the vascular system. There's cardiogenic shock, where there's a problem related to the heart, and obstructive shock, where there's a problem related to the circulatory system. So if we're going to guess which is the least prevalent type of shock, it probably will not go without a major shock. That the obstructive shock is actually the lowest type of prevalence in the patients that are developing those shock states. And then tied for second and third will be our cardiogenic patients and also our hypovolemic shock patients. Those are tied at 16%. So then that leaves us with our distributive shock, which includes septic shock, at around 66%. And of that 66%, septic shock makes of that grouping 62% of that. So it really is just something that is very disruptive to the patients. We're looking specifically at distributive shock. Again, it encompasses both sepsis, anaphylactic, and neurogenic shock. And remember that septic shock is about 62% of this grouping. It's a shock state that affects the vascular system, like I said before, where the intravascular volume is redistributed. There's a loss of vascular tone, which leads to vascular shifts, and it shifts the fluids from an intravascular to an extravascular state. And then I could have a whole entire lecture about shock where we just are talking about each one. But since we are talking about septic shock and sepsis with AKI specifically, I'm just going to talk mostly about distributive shock today. So one thing to remember is that sepsis is a syndrome. It's not one specific illness. It's not one specific event. It's a syndrome that really is very complex. And when we're looking at the sepsis definition task force, is syndrome of physiologic, pathologic, and biochemical abnormality. CMS echoed that statement where they said, really, it's not one specific thing, but it is a syndrome of illnesses. And then looking again at the surviving sepsis, it's patients can develop an infection frequently, and it's not something unheard of, but it's how the patient's body responds to that. And it's the patients that are developing sepsis have a dysregulated host response. So it's like your response is like going in overdrive, trying to treat this infection, and it just is not a normal response to it. And then again, the National Institute for Health also echoed that, is that it's just how we're responding to this bacteria that's present in the body, and how the patient is handling and coping with that. When we look at the SEP3 definition, it really looks at the Q-SOFA score, which is the sequential organ failure assessment, and looking to see if I am going to have 2 points higher than 2 points higher on the Q-SOFA score. So it's looking to see if I have hypotension, altered mental status, or tachypnea. And then if the patient isn't able to respond to treatments, they could go into this shock state, which is where I'm having refractory hypotension, even with vasopressors on board, and I'm having an increase in our lactic acid production. So I know that this looks very easy to understand, but this is the pathophysiology of sepsis, and I'm going to break it down for you into easily obtainable sections so you can understand what is truly happening. And really, the first thing that's happening is that there is a triggering event based on some type of bacterial source. The most common sources are gram-negative or gram-positive bacteria. Often, though, about 35% of the time, it'll be in relation to some lung infection, such as pneumonia. About 25% of the time, it could be related to urinary tract infection, and then so on. But there's some event that is triggering this cascade to start to flow. Once that triggering event happens, then there's a release of pro-inflammatory cytokines, which then start to activate this complement coagulation system. The complement system, the coagulation system, the kinin, neutrophils are activated, and then those monocytes and macrophages. And then what happens is that in response to these pro-inflammatory cytokines being activated, then the anti-inflammatory cytokines are saying, hey, something is happening. I need to make sure that you stop having all this inflammation. And then you go into this vicious cycle, which can replicate many times as the patient is starting to fight this bacteria that is invading. If I'm not able to stop that cycle, the patient will then go and start to develop this endothelial dysfunction. And I'll start to see things in the patient such as capillary leak. That's where we're starting to have those fluid shifts, thrombus formation, adhesion of cells, hypoxia of the tissue, cell death, impaired vascular tone, and also free radical damage. Again, the goal is to identify that the patient is in some type of shock state related to the sepsis, identify that, and then start treatment as soon as you can in order to stop these pathways from happening. If I'm, again, not able to treat the patient successfully and they're now progressing into this multi-organ dysfunction, I'm going to start to see problems in the central nervous system. And one of the things that I'm going to probably easily see in our patients is some type of altered mental status change. When I'm looking at the respiratory system, I'm going to start to see the patient developing tachypnea and also having disruptions in their PF ratio. So if you're thinking about patients with ARDS, we know that we start to get nervous if we are having around over less than 100, but these patients are going to start to show with septic patients less than 300. So they're starting that cascade of lung involvement. If I'm looking at how my renal function is happening, I'm going to start to see alterations in my urine output. Cardiovascular, my patients are going to start to be hypotension, and they're going to be tachycardic as well. I'm going to see in the hematologic, I'm going to start to see some thrombocytopenia, increase in my D-dimer. Metabolic, I'm sure people can start to think that I'm going to see lactic acidosis. I'm going to see a metabolic acidosis. And then finally, in vascular, I will start to see a poor capillary refill. Again, it's all related to that, those vascular shifts from the intravascular to extravascular. Again, if I'm not able to get the patient to respond to treatment, ultimately what I'm going to see is the patient will expire. So after that easy to understand background on sepsis and the pathophysiology. I'm going to hand it over now to Tracy, who is going to talk about acute kidney injury.
Thanks, Heather. Before we can go into acute kidney injury, it's very important to understand what normal kidney pathophysiology looks like. And when I say normal, that's under the pretense that we have great blood pressure, everything looks open, there's no existing disease. And it's really helpful to know that the kidney is really a pressure and flow-based system, meaning if I manipulate pressure, if I make it too high or too low, that's going to impact my kidney. If there's something blocking that flow, such as damaged vasculature or anything like that, that can also damage the overall function of the kidney. So knowing that and knowing what we have in the kidney, we have tiny little nephrons, and the average adult has about 1 million of these. Some have more, some have less, depending on size of kidneys. So we're going to take a look at one of these now, and you have one on the left side of your screen. And so let's talk about what blood flow really looks like inside of our kidneys. So we do get our blood coming from our renal artery, and that's going to branch into some of these little smaller arteries, and that creates into the efferent arterioles. And so those are going to lead into the glomerulus. And from here, it almost looks like a ball of yarn. But the glomerulus is really this network of capillaries, and that's where the blood filtration actually begins. And that's where blood pressure is going to force water and solutes out of that blood and into the Bowman's capsule, which is that overall structure around. And that's going to be forming the filtrate, or what's going to be coming out of your kidneys. And as that blood moves out of that glomerulus, it's going to go into what we call our efferent arterioles, or going into our effluent. And these are going to branch into further capillaries in something called the vasa recta. And these are really absorbing and secreting some of the different solutes that we see in transport in the kidney. And then finally, that blood is going to filter through into the renal vein. And this is going to ensure that our kidneys can effectively filter that blood and remove waste products. And so it's really important to understand that we have over 1 million of these. And on a larger scale, when everything's going well, it works well. But unfortunately, if we have something like sepsis, this is where we can now have redistribution of solutes and some difficulties, and we will have trouble maintaining homeostasis. So then, now that we have blood flow looked at, let's talk about what filtrate removal looks like. So again, we're going to look at one of those single nephrons over on the left-hand side. And we see that this filtrate is going to enter into that glomerulus, which is that kind of ball network that we have. And so you're going to see substances like glucose, amino acids, your proteins, vitamins, lactate, urea, and some of your ions, along with water, enter into that nephron. As it moves into the tubule, which kind of looks like that corkscrew that's kind of coming up and then sloping down, you're going to see most of those nutrients plus water are going to be reabsorbed back into that blood. And this is where we have that property of diffusion, meaning I have where I want my blood to be and I have what my solutes look like, and you're going to have that chemical process move across. And so this is going to account for about 70% of all kidney reabsorption properties. That's really important to know, because if we have any damage to those tubules, that's where we can see some of these electrolyte abnormalities. And so we'll also secrete things in this process, right in this proximal convoluted tubule. So things like urea, uric acid, creatinine, some of our medications, as well as nitrates, they're going to be secreted into the tubule to start moving out into our urine, which is the eventual product of this. So then going down into the loop of Henle, we're going to see that water is reabsorbed. And this is also going to be on a chemical-based reaction. For that, we'll also see ions such as your sodium, your potassium, and chloride are reabsorbed. And then going into the ending part, going into the collecting duct, we're going to start seeing more of that water. Some of the urea is going to be coming out as well, and creating that final urine product. And so the goal of this then is going to be that exchange. And so now that we've talked about all these pieces, let's talk about what medication interaction really looks like in the kidney nephrons. So looking at these, as we talked about, our blood plasma is going to enter into the glomerulus, and it's going to allow all those pieces, like all those different substances like glucose, amino acids, and everything enter into the nephrons. As it moves out of that proximal convoluted tubule, this is where we see some of that reabsorption, in the bulk of it, about 70%. And so this is where osmotic diuretics interact. So substances like mannitol is probably going to be one of the most common that we use. So in osmotic, if you think about the property of this and you think about some of that reabsorption and what happens in osmotic diuresis, we have a large amount of urine that comes out of that. As we're coming down into the loop of Henle, we see that water reabsorption happen, as well as some of those ions. This is where our loop diuretics, such as furosemide and butanamide, also interact. So on that loop of Henle. And then as we go into the distal convoluted tubule, so coming out before it goes down again into that collecting duct, you're going to see your thiazide diuretics interact. So hydrochlorothiazide and thiazide are two of the most common ones that we see in those. So depending on where we want to interact with our reabsorption and secretion properties, we can dial in that effectiveness through different types of diuretics. And then finally, our collecting duct is where we have the final adjustment of water and different solutes based on your body's needs. And so one of the most common that we see, this is where potassium sparing diuretics are going to be used, such as spironolactone, to give that overall summation of therapy. And so your final urine is going to contain water, it's going to contain urea, ions, creatinine, and other waste based on what my functioning kidney is looking like, as well as any medications that are interacting in that. And it's really important that we know this, because we consider this is when a functioning system happens. When we have acute kidney injury and we have devastation of these nephrons, these million nephrons that we have, we know that we already have an issue happening. And then if we add medications on top of it, which sometimes happens in care while we're still recognizing that the patient's in a failure state or an injury state, this can further change that reabsorption of nutrients and ions. And so now that we've covered medications, we're going to talk about how hemodynamics are impacted in the kidney. And so when we look at kidneys and hemodynamics, there's a very intricate system called the renin-angiotensin system, or RAS. And this is a hormone-based system that really regulates our blood pressure, our fluid balance, and electrolyte levels. And so the first piece is going to happen in the kidney. So when blood pressure drops, and this is going to be by the inside of the body, blood flow to the kidneys is going to decrease. Or if the sodium levels are low because it's thinking that there is a decrease in your blood pressure, the juxtaglomerular cells in the kidney are going to release an enzyme called renin. And from there, renin is going to act in the liver into, it's going to be made into angiotensinogen, and that's going to convert it into angiotensinogen 1. This is an inactive form. And so as that circulates, we now need the lungs. And so this is where in sepsis, when we have that multi-system organ failure, this is where blood pressure can go awry very, very quickly if we have things like liver shock and we have lung injury in some of those pieces. So in a normal functioning lung, we now have angiotensin converting enzyme, or ACE for short. This is going to convert angiotensin 1 to angiotensin 2. Now it is an active hormone, and it can now raise that blood pressure. So that's going to come back into our kidney, and that's going to narrow our blood vessels. That's going to raise our blood pressure. It's also going to stimulate the adrenal glands to release aldosterone, and that's going to increase sodium and water reabsorption in the kidneys. So we're going to have less urine and more volume back into the blood, so we can raise that blood pressure in case it's a blood loss situation. So when that happens, we're also seeing antidiuretic hormone also be released. That's going to be released from the pituitary gland, and that's going to further increase water reabsorption. So we're going to see less urine output from these patients and an increase in blood pressure in a normal functioning state. Now, if your patient's able to talk to you, what you'll find in this instance is they're also thirsty. They might tell you, hey, I'm really thirsty, or I feel like I need some water. Unfortunately, in critical care, we don't always see that because our patients are not able to always talk to us or converse with us. So the outcome from this is you get a blood pressure rise, you get sodium and water conservation, and your circulatory volume is stabilized. And Interestingly enough, about the kidney, when you look at the kidney in an overall function and trying to put this in perspective, your kidney is going to consume approximately 10% of oxygen from your body's needs. And that's based on your cardiac output. It'll also take about 25% of that overall cardiac output. So the kidney is a phenomenal set of organs that we have that needs to function appropriately. So now that we've covered pathophysiology and how medications interact and how our kidney hemodynamics work, let's talk about how to monitor the diagnostics of overall kidney function. So the first and foremost or most common that you're going to look at in critical care, and I think about the times when I was a new grad nurse, the number one thing that I looked at was, what's my patient's urine output? Do they have urine output? What's the quality? What's the character? What's the color of it? And I think it's really important to know that it's important, but it's not the only indicator. And the reason why it can be skewed for various reasons. Relying solely on urine output can be misleading and it can actually delay outcomes if we're fixated on it. Both quantity and quality is important. However, evidence-based practice tells us that we should have at least a certain amount based on the type of your patient. And so that should be 0.5 mLs per kilo per hour for urine output. That tells us based on the size of that person in the bed, we should see at least that amount to say, okay, the kidneys are working effectively. If it's falling under that, now our suspicion needs to be raised. Is my kidney injured? What's going on? And so we also need to ask ourselves, why? Why is this happening? Why is my volume changing? What am I giving? What's going on with my patient? That something's changing. And so decreased urine output can be for a variety of reasons. It can be to preserve our urine volume, our blood, our body volume. It can be a side effect of different medications or therapies. It can also be because our electrolytes are trying to normalize. It can also be because of dehydration or other different types of conditions, including sepsis. Increased urine output, on the other hand, can be due to ischemia within the kidney or the inability to concentrate urine. So, for example, tubular dysfunction, where we don't have reabsorption and it just lets everything out. So, that's urine output. It's a great indicator, but it's not the sole one. So, let's talk about other diagnostic tests that we can use. So the second that we see that the most common and one of the most widely reported is going to be serum creatinine or SCR. And this is a very common functional biomarker that we use. And we use the term biomarkers a lot in evidence-based practice now, and you hear them, and sometimes you think, okay, well, what's a biomarker? Serum creatinine is a great one. It's a functional one, and it's used to overall assess kidney function, and it's a key component in measuring a specific process called the glomerular filtration rate, or the ability of that ball that we had inside of each of those nephrons to be able to filter out that blood. This is produced in the kidney, liver, and pancreas, and it is eliminated by the kidney through that glomerulus. So it's important to know this. So this can give us an overall function of kidney health. And so if we have a couple different things going on in the kidney, you will see a variation in serum creatinine. Again, serum creatinine is a great indicator, but it's not the only tool in the toolbox. It should be used in relation to everything else that's going on with your patient. And so some advantages of serum creatinine that we see is that it's widely reported and used. It's used in many different types of labs. It's relatively cheap when you consider the price of some of the other biomarkers that we have. And it's pretty easy to obtain with a simple blood test. Some of the disadvantages that we have, though, it's a delayed marker in acute kidney injury. And unfortunately, we see patients that are currently in injury, and it takes a while for serum creatinine to catch up. It's also not specific to the cause of injury. It just tells us something's going on. It doesn't tell us what specifically is going on. And sometimes it can also provide false reassurance as AKI worsens. And so you can overestimate it in patients with decreased muscle mass because of advanced age, or even chronic diseases like liver failure or cancer, because again, it can be coming from more than one organ. However, we can also see that it gets overestimated in things like massive volume resuscitation and certain drugs, because you can congest the renal components or the kidneys. You can also have different damage. And for patients that have larger muscle mass, like athletes or bodybuilders, or patients with diets with red meat, you may see false sensitive or reduced sensitivity of serum creatinine. So we're going to continue to focus on some of the other diagnostics that we have. So the second diagnostic that we have that we're going to talk about is eGFR, estimated glomerular filtration rate. And this is the rate at which blood is filtered through the kidney, and it's determined by molecular size and shape that's going through all the components of reabsorption and filtration. This also takes into account the patient's creatinine, their age, their gender, weight and muscle mass, and their race. So this is a really good tool for risk stratification to tell us, is this patient at high likelihood for acute kidney injury? It also can tell us when we look at evidence, what's their higher likelihood of being admitted to the ICU, as well as mortality. Can they survive whatever they're going through based on their eGFR? And according to the KDIGO guidelines, which we'll talk about shortly, an eGFR of less than 60 mLs per minute per 1.73 meters squared is significant, where we need to take action. So something that you'll see in evidence coming out more and more is KeGFR or kinetic eGFR. This might allow earlier detection of AKI, and we might see this through acute changes because it's becoming more sensitive to serum creatinine. But we need to caution ourselves with eGFR because it can be delayed because of an inaccurate serum creatinine. So again, it's not the only tool you have in your toolbox. There's a lot of other things, and it's a global assessment. We need to combine it with urine output and your patient assessment. And so let's talk about more of the biomarkers that we're seeing in evidence to help with kidney function. So we have our functional, and then we also have some of the damage pieces or expanding roles that you'll see. Cystatin C is probably going to be the most common one. This is really less reliant on muscle mass and than serum creatinine and eGFR. And so this can help predict chronic dialysis in certain patients, especially at the end of renal replacement therapy. In normal conditions, we do see that cystatin C is not really detectable, but it is present if there's damage to the glomerulus. So that tells us that damage has happened in the inhibition in the inability to filter those out. However, we do need to caution, though, that cystatin C can be elevated or falsely lowered in patients with thyroid conditions. So that's something that we also need to evaluate as a global assessment. We see, though, that in expanding roles for AKI, we see that some of these biomarkers are becoming really useful in monitoring nephrotoxic drugs and treatments and detecting the onset and presence of kidney damage. So this is really important as we consider things such as sepsis in certain conditions. So next we'll talk about our role of other biomarkers in AKI. And so we have some risk assessment ones. We have certain ones for prediction of early interventions and everything like that. So our kidney health assessment is really one of them that we recognize to look at AKI susceptibility before your high risk exposures. And we see, so there's certain biomarkers like Dipcoff and 3, and then also cystatin C. These can really identify patients at high risk of AKI before your clinical signs are going to appear. From a prediction, certain biomarkers, TIMP2 and IGF-BP7, these are validated for predicting AKI and for guiding preventative strategies to try and prevent patients from moving on to chronic dialysis. And so these can really help, especially when we look at KDIGO guidelines, to prevent severity of illness. When we look at diagnosis and etiology, some of our damage biomarkers that we have here, which is NGAL and KIM1, and our functional biomarkers, which is cystatin C and serum creatinine, these improve your diagnostic accuracy. So again, not one tool in the toolbox, using a global assessment, using multiple biomarkers to really help guide diagnosis as well as interventions. And so when we look at recovery and prognosis, we see several different ones are associated with AKI duration and recovery. And if we see persistent elevation in these biomarkers, what evidence is starting to show is that we're seeing these correlate with poor outcomes, including dialysis dependence and unfortunately mortality. So this is exciting. This is evolution of evidence-based practice. And one of the things that you'll see in evidence coming out is more linkage to specific components of renal injuries, as well as adherence to certain things like KDIGO guidelines. So now that we've covered biomarkers, let's talk about how we classify acute kidney injury. So our KDIGO guidelines came out in 2024, and you'll see a couple things in here. And so one of the things that we notice is urine output is a bit controversial because it's often not caught early enough. Depending on where you are in critical care as a nurse, you can see that it's not something we always keep on top of when we think of everything else that we have to do during your shift, right? So and we see that it also manipulates based on multiple factors outside of acute kidney injury. You consider using other things like eGFR, unless you can have serum creatinine, as well as cystatin C or something along those lines. When we look at KDIGO guidelines, really tell us that acute kidney injury can really be any one of the following, whether you have that increase in your serum creatinine, depending on how long or that time duration, or that urine output for less than 6 hours. And when we look at the roles of other different biomarkers, it's really important that we look at something like your eGFR in addition to your assessment, in addition to your different biomarkers. Something that we did not talk about on the lower right-hand side is ACR, or albumin to creatinine ratio. This measures the amount of albumin compared to creatinine to detect severity of kidney damage. And the important thing to know about this is albumin is typically found in blood, not urine. So the indication of this in urine points to kidney damage. This can be really useful for patients with diabetes, high blood pressure, or chronic kidney disease. And so this is really important, but it's really important to know also that other biomarkers outside of these things are still under review. So more to be continued. So what we currently have from an evidence-based practice standpoint is we have acute kidney injury in two different scales. You have the Rifle scale and you have the Aiken scale. And the Rifle scale has been around for quite a bit of time, and it uses serum creatinine and urine output to really classify kidney injury for the first three levels. And if you look at the top on the right-hand side, you'll see risk, injury, and failure. And then the last two really look at your outcomes for kidney failure, and that's loss and end-stage renal disease. The Aiken was developed to really improve that sensitivity and specificity of the Rifle criteria for the first three, and really explain those first three levels, so that risk, injury, and failure. And it's really important to know where your patient is. These should be documented when we're looking at patients going into acute kidney injury, where they are within this scale, because this can help us understand what some of our interventions might be, what some of our monitoring might be. So important. However, what I also have to stress though is while this is great, we also need to figure out where is the injury. So looking at our injury, there's a couple different classifications by region and cause agents. So we have pre-renal failure, intrarenal failure, and post-renal failure. So your pre-renal failure is going to be reduction in blood flow. And one of the most important pieces to really consider is pre-renal failure largely is preventable. We need to figure out what's going on, and we need to stop that pre-renal loss of blood flow so that it doesn't impact the kidneys for too long, that it throws them into an injury or, unfortunately, a failure state. Intrarenal really looks at our hypoxia or injury. An injury can be a direct injury if there are trauma, or even an injury related to medications or something that we didn't quite monitor effectively, and that includes recreational substances. And then post-renal is really that obstruction, and that can be from stenosis or even things like stones or calculi. The most common that you're going to see, especially when we talk about sepsis, is going to be pre-renal failure. And the reason why is because of distributive shock, like Heather said. And the most common type of AKI with our distributive shock and sepsis, this estimates about 60% of pre-renal injury cases. It's really important that we take care of these patients. We recognize this early, and we start our interventions to prevent further loss or escalating into a failure state. You see the other ones that we have here, so things like hypovolemia, vessel conditions, medications, and decreased cardiac output are exceptionally important. But unfortunately, sepsis is a very common agent. Now, talking about sepsis, we're going to go into just what are some of the differences between SAAKI and AKI. And so when we look at that, you're going to see on your left-hand side, So SAAKI really includes ischemic or nephrotoxic causes. There's multiple reasons for this. Heather did a great job talking about mitochondrial injury, inflammation, and just that overall failure state that happens with multi-system organ dysfunction and endothelial dysfunction. And it's really helpful to understand that this is diagnosed within 7 days after a sepsis diagnosis. We consider it early if it's less than 48 hours, but if it's between that 48 hours to 7 days, we consider that late because we've already had damage there. We've already had issues with reabsorption and secretion. And so what it doesn't include is injury related directly to indirectly to a consequence of sepsis or sepsis therapy. So most common is going to be some of those antimicrobial agents. So some of those antibiotics can be extremely strong. They can be nephrotoxic. And especially when we look at just fluid shifting and some of the things that unfortunately happen or some of the sequelae that happen from sepsis, it is not part of that, such as abdominal compartment syndrome. But some interesting pieces to know about sepsis and why we care about it so much with sepsis AKI is it's attributed to up to 50% of AKI conditions. And up to 60% of patients with sepsis do have AKI. Whether or not we realize it and pinpoint it, we need to know that they do have it. The majority do have it. It increases your morbidity and mortality, and it can also increase hospital mortality up to 8-fold. So it's very important that we highlight these and that we figure this out and use our tools to do this. And so now I'm going to hand it back to Heather to talk about patient management.
Great, thank you, Tracy. All right, so we defined and looked at the pathophysiology of not only sepsis, but also sepsis-associated AKI. So let's figure out the best ways that we could start treating it. So one of the first thing and one of the most prevalent recommendations is to follow the Surviving Sepsis campaign, which was developed by Manny Rivers many years ago. Really, it focuses on drying labs, administering antibiotics, giving that fluid resuscitation, and restoring hemodynamic instability. So the first thing we need to know is how to establish a time zero. So if you have an EMR that might be able to gather information, you could utilize that. Like for instance, at my facility, we will have time zero based on when a specific alert fires for us. Whatever you're using, just make sure you're consistent and that everyone across your facility will utilize the same method in order to determine time zero. Once that time zero is triggered, then you have 3 hours to make sure that you draw your lactic acid, blood cultures, broad spectrum antibiotics, and then make sure that you're giving fluids. And they're very prescriptive about how much fluids that you want to give. Remember, these patients are really vascularly depleted because of that shifting of the fluids into the different spaces. So you want to look at giving your patients about 30 mLs per kilo based on their response to their fluid status. Once you have completed that 3-hour bundle, there is an additional 6-hour bundle that we want to make sure that we're paying attention to. So that's making sure that our patients are being able to handle their hypotension, making sure that if we need to restart some vasopressors or something like that to make sure that they have an adequate mean arterial pressure. We want to make sure that we're repeating our lactic acid. If it was greater than 2, you want to make sure that the therapies that we're giving, the patient will respond to. And then you also want to make sure that you're having a physician at the bedside to lay eyes on the patient and make sure that we, again, are being successful in how we're treating the patient. When we're looking at, so we're going to make sure that we're getting the sepsis under control. But one thing we want to make sure is that you have an extension of where we don't want it to proceed and start really affecting the kidneys and develop into that sepsis-associated AKI. So beyond the sepsis treatment, we want to look and see if these patients need to have some type of extracorporeal treatment. We want to look at our fluid resuscitation and making sure that we're utilizing a dynamic measure in order to know how much fluids that we're giving and if we are successful in that. And then we also want to look at see what types of vasopressors that we are going to give. Again, we're going to look and see what the ADAKI consensus committee was recommending is specifically in these types of patients. We're looking at the extracorporeal treatment. We're looking at patients that are going to potentially receive continuous renal replacement therapy, TPE you can have, peritoneal dialysis, and in some cases also albumin dialysis. But those are the major types of extracorporeal treatment that we're going to look at. We're going to also make sure that we're paying attention to the types of therapeutic principles that, and I'm going to discuss this in a couple more slides, but making sure that we're paying attention to what therapeutic principles that we are going to utilize when treating our patient. So making sure that we have diffusion on board, making sure that we're looking for convection, and then also that absorption. We're going to make sure that the emergent indications for AKI and sepsis-associated AKI, if the patient is in an emergency state or really hemodynamically unstable, it doesn't matter what the definition is. It just says, make sure you're treating the patient, and then we can work out that definition at a later time once the patient is stabilized. You want to make sure that you have good immunomodulatory support, such as the AMPs and the DAMPs. Want to make sure that we have the therapeutic outcome measures to determine how effective we are in treating. So you need to know how to measure where our endpoints are. You don't want to just be treating the patient blindly, but know what are our end goals. So if it's like, say, mean arterial pressure, then everyone is on the same page to know that I'm going to give these medications in order to get that map at a certain level. And then also looking at those patient-centered care goals and making sure that we're within the requirements of what the patient and their families want. This is where we're talking about those therapeutic principles and looking at the four major ones when we're running patients on CRT is looking at ultrafiltration, which is where we're removing extra fluid. Diffusion is removal of the small and medium molecules. A lot of times that is by using your dialysate fluids. Convection is really looking to remove the large and medium molecules. So in patients with sepsis, they have a lot of large inflammatory mediators. So convection is a key therapy that we want to make sure that we are able to deliver to our patient to help resolve that sepsis as soon as we can. And then finally, we look to absorption, which is what the filter is made up of. It's negatively charged. It will attract the molecules that are kind of causing a lot of these problems and then attach to the filter, and then we would exchange out the filter. So kind of cleaning that filter and getting a new surface area to have those molecules that are being negative to our patients. So we want to make sure that we're utilizing all of these principles when we're taking care of these types of patients. Again, we want to think about what fluids that we're going to use. So we want to make sure that we're replicating what the Surviving Sepsis campaign is dictating for us. We want to make sure that you also have a daily and cumulative fluid balance. So again, you know what you're monitoring, you know what endpoints. You don't want to just give fluids or remove fluids without knowing what the daily balance is for those types of patients. You want to make sure that you're administering fluids to dynamic measures and making sure you know their endpoints. You want to give the fluid resuscitation you should use is going to be 0.9 NS or albumin or bicarbonate. However, they do recommend against using starch, gelatin, or dextran. You want to also make sure that if you're using vasopressors, that you know which you should start those early rather than later. When I was when I was brand new nurse, I'm like I said, 30 years in, we used to look to starting vasopressors as our last resort, and we really don't want to look at that. We want to start those as early as possible for our patients, and norepinephrine should be your first line that you're going to start with. And then you want to also give vasopressors in combination with volume as long as your patient can tolerate it. If your patient does get fluid overloaded, they're not responding to your CRT treatment, then you want to make sure that you can give also a diuretic in response to that fluid overload. And then if the vasopressors, if Levophed is not effective, then you want to start thinking about escalating and combining your vasopressors. So maybe bringing in vasopressin or even angiotensin II to help treat your patient and maintain their hemodynamic stability. So again, I talk about giving a lot of fluids. These patients, like I said, are very fluid depleted, and we want to give a lot of fluids, but you need to know there's a lot of evidence that says that giving too much fluid is actually more detrimental than not giving enough. So we want to really making sure that we are making sure that we have our specific endpoints. So the outcome should focus on seeing improvement with the patient's oliguria, hypotension, or tachycardia, and then evaluating the fluids based on physical examination alone, such as assessing the mucous membrane, JVD, distension, or capillary refill. Those are actually very poor predictors, and those are not something that we should rely on. If able, if you can have other ways. So you can look at maybe having a static measure such as CVP in your toolbox to take care of these patients. Now, no, CVPs are not very predictive either, so we have some problems with that. But if that is what you have, then that's what you could use. What really is the best way to measure the effectiveness would be using dynamic measures such as pulse pressure variation or stroke volume variation. You can also use ultrasound assessment of respiratory variation. And then you can also use the passive leg raise, or PLR, is also an effective dynamic measure to use for your patients. Just remember, we utilize that Frank-Starling curve all the time, and it will help us know, because we know that only about half of our patients are going to respond to fluids, and they may respond at the beginning of their treatment, but then they'll reach this peak where then the second half do not respond. So you can continue giving fluids, but your patient will not respond hemodynamically, and you need to start thinking about those vasopressors. So you know that then we should start to be thinking about what we're going to start administering next. And there are a lot of different recommendations about what vasopressors to use. There's many big facilities that have done these big random controls trials. But really, if you think about how we're going to escalate the order of giving our vasopressors, we're going to start with Levophed or norepinephrine. We're going to then progress to vasopressin if the patient is not responsive. And then our third line treatment will look at that angiotensin II or even an epinephrine drip as well. So we talked about how to manage the patients through sepsis. We talked about how to think about using extracorporeal treatments, making sure that you're also administering your fluids and then also your vasopressors. So in summary of our presentation today, just know sepsis is deadly. It has a high mortality, high morbidity. And then the pathophysiology, not only with sepsis-associated AKI, but also sepsis, is complex, but it does have some modifiable factors. We want to make sure that we're administering our antibiotics, fluids, and then those vasopressors. And when we're looking at treating patients with sepsis-associated AKI, we need to think about starting those extracorporeal treatments early rather than later, making sure that we have dynamic measures to know when our fluid resuscitation has met its endpoints, and then also making sure that we're utilizing the appropriate vasopressor. And on behalf of Tracy and myself, I really do appreciate that you all spent time listening to us about some topics that are very passionate to both of us. And we welcome any questions that you may have. And then here are also our references.
Thank you.
Thank you very much, Heather and Tracy. What a brilliant presentation. Thank you so much for taking us through that, and it was really very informative. I've just checked in the chat box. I do not see any specific questions, but if anybody's got a specific question, you're welcome to just quickly maybe type it in the chat box so we can just see if there's any Any questions? Let me just quickly see. I see something then. I'm just trying to get there to
And
hold on.
Isabel, while they're waiting for questions, remind the group about the evaluation and the certificate of attendance.
Yes, I did indicate that, but I can just remind the group again that we will post in the next 2 days. You'll receive an email with a QR code, which we kindly ask you to complete. It's just a short evaluation instrument. It will really take you 2 or maybe 3 minutes at the most to complete. And there's also a section where you can also add maybe topics that you are interested in. And then at the end of the evaluation, you'll then be able to download the certificate of attendance. So far, it's just a lot of thank yous and appreciation. Oh, there's a question from
Monsef.
Monsef. He's asking, what about the use of diuretics?
That's a great question. I think from an acute kidney injury, what we see in realistic practice is when someone has reduction in kidney function, we might not know it yet, but first we see probably a reduction in urine output. So in likelihood, you may see, especially a loop diuretic, so something like furosemide. I know in the States that's very common to what we give. I don't know if Heather sees might be seeing something different, but at that point, that is also where you need to guide any sort of resuscitation that you're using, whether it's with diuretics or something else, with your different biomarkers to take a look and see, is this patient needing a diuretic to actually remove that, or do we need to take a look at what is actually going on with this patient? Do they need to have a different approach? Do we need to look at blood pressure management, or actually what is the quality of that urine, not the content, and not the I would say not the quantity of that urine. Heather, what do you think?
Yeah, I totally agree with you, Tracy. I think also there is this delicate balance that we go through where we're managing the patients and you do start to see that fluid overload. So some providers will start to think about utilizing some diuretics, but you don't want to go down the slippery slope where then we're going to start fluid depleting the patient that is already fluid depleted. So we're going to spend time resuscitating them with fluid. We just want to make sure that they stay that resuscitated to making sure that we're able to maintain their MAP and et cetera. So having those dynamic measures can also help along with that to make sure that the patient is responding appropriately. But sometimes you do have to have that combination between fluid resuscitation and diuretic.
Thank you very much for that. I also see there's a question that I know is always asked, but it's so important. And Monsef is also asking, is there any place for dopamine?
Yeah, that's a great question. So dopamine is something that I do still see it used. I have a cardiac population, so occasionally we will use it, as well as the inotropic version of that. So dobutamine. The problem with dopamine is that it is a beta. It's a beta stimulator. So meaning your patient already has tachycardia. So if you're going to use dopamine, you're going to increase that tachycardia. You can see some negative effects from that. You can see them going into supraventricular tachycardia. And in lower doses, dopamine, we used to have what we call the renal dose, meaning if it was under 5 mics per kilo per minute, you would see this influx of urine, and that's great. But you also have those negative side effects. We can also see some cardiac instability from there. We can actually see if somebody has a heart history or cardiac history, we can actually see worsening of their cardiac function. You can even see chest pain. So we try not to utilize dopamine as much anymore just because of some of those negative effects that we see. That's a great question.
Thank you so much. And there's also a question from Belinda. If a patient is in respiratory failure, will it reduce angiotensin 1 to angiotensin 2 conversion? I'm
Absolutely.
sure it
Heather,
must be renal failure. I think she made a typing error.
yes. So if you do have lung failure, respiratory failure, or lung disease, you can inhibit the use of angiotensin 1 to angiotensin 2. It can be reduced. You will see that that does, unfortunately, if there is reduced oxygen carrying capacity and oxygen exchange or oxygen ventilation exchange, you will see that a reduction in angiotensin too, unfortunately.
Thank you so much. And then Albulkar is asking if there's any, has phenylephrine or phenylephrine have any role?
I think so. So phenylephrine can, and Heather, I'd love your thoughts on phenylephrine. So Heather takes care of trauma patients, and she sees a lot of neuro and trauma patients. So they tend to use more phenylephrine than I do in my practice. So Heather, what are your thoughts on phenylephrine?
I think we do utilize it a lot actually. I think in regard to these patients specifically, if they're already responding and we have a good regime happening and they are then starting to have a reduction in like their MAP, we will still start Levophed. But if they are able to maintain their hemodynamic stability and they're already on something that um, works for them, we will utilize that. And I think sometimes that's where we will have almost like a kind of patient specific approach to maintaining our patients. So in the cardiac population, they may utilize something more specific. In the trauma population, we will utilize something specific as well. So if you're using something and it's working, I would continue to use that, just making sure that you have those dynamic endpoints.
I do
Thank you
want to
very
let
much.
I do want to let the audience know that we will be posting the webinar, the recording of the webinar on our website under the education section. So you'll be able to find that. Give us a few days to make that happen.
Thank you so much, Kathleen. I was just going to say that, yeah, currently the website is under construction, but we are definitely going to upload it under the education section. I don't see any other specific questions. There's obviously many thanks and congratulations and appreciation for the lecture. I'm now going to hand over to my colleague Joseph just to do the vote of thanks. I just quickly one final check. Yeah, I think those are all the things. Much. Over to you, Joseph.
Thank you, Isabel. Thank you very much, Heather and Tracy. On behalf of the World Federation of Critical Care Nurses and all the participants in today's webinar, we extend our deepest gratitude to the Heather and Tracy for their outstanding contribution to this session focused on the protecting renal function in the septic adult. Your expertise, clarity, and passion for advancing critical care nursing have enriched our global community and inspired us to continue striving for excellence. Thank you for sharing your insight with such generosity and professionalism. We warmly invite you to join and us again of coming webinar. We will continue to build bridges and knowledge, collaboration, and innovation across borders. With admiration and appreciation, World Federation of Critical Care Nurses, United for Excellence in Critical Care Nursing. Thank you very much, Tracy and Harry. Thank you very much, Isabel and Kathleen.
That will end the webinar.
Thank you. Thank you very much, Joseph, and to all our colleagues across the globe for joining this webinar. And again, just for Tracy and Heather, your time and really your passion it is always so nice to have speakers that you can really see this is their passion, and we do appreciate that. Kathleen, any final words from you before we greet?
No, we're just happy to have everybody join us and access this on the website, and look forward to the next one.
Yes, thank you so much. And we will